Hello, everyone, and welcome to MSK Unknown Case Series, week 49. Here we have a phenomenal case. We have a frontal or an AP view of the pelvis and the sacroiliac joints. And the question that I have is, what lab abnormality would this patient test positive for? Rheumatoid factor, HLA-B27, anti-Smith antibody, anti-centromere antibody. What lab abnormality would this patient test positive for? So we come back to the plain film. Notice, first of all, that the sacroiliac joints actually look pretty good, right? We see a little bit of subchondral sclerosis, maybe subtle erosions here, but it's very hard to tell. There's no evidence of trauma. This is the iliopectineal line, which represents the anterior column of the acetabulum, the ilioischial line right here, which represents the posterior column of the acetabulum. There's no fractures. The hip joint spaces are congruent bilaterally. If we take a look at the spinous processes here, there's fusion of the spinous processes here, right? So we call this the dagger sign. This is commonly seen in some of the seronegative spondyloarthropathies, particularly ankylosing spondylitis, right? So the fact that we have the dagger sign here, fusion of the interspinous ligament or the spinous processes here, this would be seen in HLA-B27, right? So that would be positive in this patient with ankylosing spondylitis, and the dagger sign that we see here with fusion of the interspinous ligament or the spinous processes of the lumbar spine. So ankylosing spondylitis, as you know, is one of the 4 seronegative spondyloarthropathies that affects the axial skeleton, right? It particularly is going to affect the spine. You may have arthritis in some of the large joints like the hip and the shoulder, but almost never really affects distal part like the hands or the feet and things like that, right? Ankspon, IBD arthropathy, psoriatic arthritis, and reactive arthritis are the 4 seronegative spondyloarthropathies. Now, we often group Ankspon and IBD together because they tend to produce bilateral symmetric sacroiliitis, and we tend to group reactive arthritis and psoriatic arthritis together because they tend to produce bilateral asymmetric sacroiliitis, right, in the sacroiliac joints, right? Now, all can produce bilateral symmetric and bilateral asymmetric, but we characteristically group those 2 together of the 4 seronegative spondyloarthropathies. Ankspon is particularly common in a young male and a young white male with back pain. So anytime you have a very young person that has back pain, the first thing or one of the first things you should always think about is ankylosing spondylitis, okay? That's a very important clue to the diagnosis of Ankspon. This is obviously common in whites, Native Americans, and males. That's not to say that females, or that's not to say that African Americans can't get this diagnosis, but obviously very common in white males, particularly white young males. This often presents with back pain. That's the initial presenting factor. Back pain for unknown or unusual cause, right? They didn't have trauma. They don't have a pars defect. Back pain for a reason that's not well known. Radiographically, as I was saying, Ankspon is radiographically identical to inflammatory bowel disease arthropathy. So arthropathy that's associated with Crohn's disease or ulcerative colitis. Now, clinically, they're totally different, right? Like, IBD arthropathy is going to have abdominal symptoms with abdominal pain, terminal ileitis in the setting of Crohn's, or, pancolitis in the setting of ulcerative colitis. But, radiographically, they're going to look exactly alike. And it's often hard to distinguish the 2 of them without clinical history. And for Ankspon and IBD arthropathy, you want to look for bilateral symmetric sacroiliitis. So erosions that involve bilateral SI joints in a symmetric distribution, right? That's the key to diagnosing ankylosing spondylitis. There are certain signs that are also important, like the dagger sign that I just showed you in our index case for fusion of the spinous processes. You can also have the trolley sign, which is fusion of the facet joints, right? Fusion of the facet joints on each side of the spine that give the trolley sign, right? So those are all very important signs in the setting of ankylosing spondylitis that can be a clue to the diagnosis. And now, often some people say that the classic teaching is that the sacroiliac joints will be involved first, and then we will see findings in the spine. But that's not always the case, as in our case. Now, the SI joints may have been involved in our case, but they weren't as dramatic as the findings in the spine or the dagger sign, right? So although that is a traditional teaching, seeing the dagger sign in the absence of SI joint findings shouldn't sway you away from making the diagnosis of ankylosing spondylitis. Another key finding in ankylosing spondylitis is Romanesque lesions or osteitis or inflammation or edema at the vertebral body corners or enthesitis at the insertion of where tendons or ligaments are attaching, right? So that's a very important sign. We typically see this on an MRI where we have T2 hyperintense edema at the corners of the vertebral bodies. That can be a very early sign of ankylosing spondylitis. And these can be precursors to something known as syndesmophytes, which are seen only in ankylosing spondylitis and IBD arthropathy. These are not seen in psoriasis or reactive arthritis, right? This represents, ossification of the annulus fibrosus of the intervertebral disc, right? We see perivertebral ossification, which is different in psoriasis and reactive arthritis, but syndesmophytes, which is a key finding in ANK-SPON and IBD arthropathy, are seen in those two diagnoses, right? And they reflect, ossification of the annulus fibrosus of the intervertebral disc. Thank you so much for your attention. Please tune in next week for another high-yield MSK unknown case. Please subscribe to our channel and support our mission to having free knowledge everywhere.